Hello and welcome to the Awakening Health Show. And today I feel very honored and really excited because someone that I've been talking to you all individually about for years and years is joining us, Dr. Stuart Nunley. And he also has one of the doctors from his practice, Dr. Lane Freeman.
Freeman. Mhm.
Yes, Dr. Lane Freeman. And we were going to talk about an area that most people don't know very much about, and that has to do with the whole area of implants. And there are, it appears, certain people that can actually use an implant with no harm to them, but others are challenged by implants. And for those of you who've never heard about that, we're going to query these two experts in the field and get a sense of when it might be appropriate to consider a implant, what types of implants to use, what types of implants can be really detrimental and why. So to begin with, Dr. Nunley, oh, and I also want to let you know these two lovely people have the most extraordinary, loving, caring, peaceful dental office you could ever imagine going to. I actually look forward to going to my dentist. I mean, my heart gets really excited when I know that I get to go. The office is beautiful. Every single person in there seems to be hand chosen for their capacity for compassion, kindness, and it seems like a heart for service. It's really special. And when we're not dealing with intense COVID breakdowns, you'll even find tea and coffee and I think organic cream and all sorts of wonderful things for you to participate with. And the office has grown, so perhaps you can tell us about the new people and the new services that you're offering. But in particular, today we're going to focus on the whole arena of implants and zirconium implants. Okay. Is that right, Dr. Nunley?
Sure, absolutely.
Okay, great. Okay, so I'm going to start out just by letting you share with us what you want to tell us about implants for starters.
Well, many people now over the last 25 years have had implants placed around the world. And I would say, at least outwardly, we have thought that implants have served people well. Of course, during that time, many health issues have arisen. There are autoimmune issues that are certainly on the rise and all sorts of degenerative diseases, cancers, and others. And we don't think about dentistry typically being either a cause of one of those or a contributor to it. But quite frankly, over the years, there have been more and more physicians and dentists who have recognized that sometimes after a patient receives an implant, sometimes there's a demise in their health, which no one can ascribe to anything else. And finally, someone says, well, maybe it was your implant, or maybe you have an infection in your jawbone. And so the area that we serve in primarily is helping people to detect where these infections are. And many times, quite frankly, they are associated with implants that have been placed over the years. And so Dr. Freeman and I both remove implants for years. Dr. Freeman placed what we think is the most biocompatible of implants, and that's a zirconia implant. But even when we did that, we were very circumspect about who we would place an implant on. The patient had to be one who was robustly healthy, and oftentimes Lane would only place one or two to make sure that the patient did well with the material, and she would have tested the patient for the material. Why don't you tell how you would test the patients?
So with the type of implant that I place is the zirconia implant, which you had mentioned, and we can get into that a little bit bit more as far as patient deciding what's best for a patient. But as far as doing some testing, the best testing that we have available to us is biocompatibility testing. And they will actually test not just for zirconia, but for specific implant systems. And a lot of the older titanium implant systems also show up on that biocompatibility test. So that's the first step that we look at. But one question patients always ask, which I'm sure that you have had this question asked to you, is are implants safe? And as Dr. Nunley mentioned, for years, we have seen many of our patients come through both with titanium and zirconia implants and seem outwardly to do well. And I think a lot of patients can tolerate those. But the most important thing for patients to realize when they're considering an implant is that it is something foreign that's implanted in your body, even if we are looking at using the most biocompatible option that we have, which is zirconia. It's still going to be something foreign. So that's the first thing to realize. It's not ever going to be natural tooth structure. That being said, zirconia and titanium are inert as far as they aren't going to have a living bloodstream running through them. So that's different than a tooth or a tooth that has died or has a root canal at that point. So the best way that we had was testing with the biocompatibility test. And then we also had some patients who actually took the actual implants and did even muscle testing and things like that to have another layer of testing with those particular materials.
Could you talk to us a little bit about the procedure? I believe it's a blood test.
It is. Mm-hmm.
Yes. Okay.
It is. The biocompatibility test is a blood test, and it can be drawn in our office, or sometimes we send kits to patients and they can take it to a lab that can draw the blood and send that in. And then we receive a report back that would contain materials anywhere from, of course, implants, but it also tells us what type of filling materials a patient is suitable for a patient, crown materials, cements, bonding agents. If patients choose to not do an implant and do a partial denture, that is also included on that biocompatibility test. So it's useful for more things than just implants.
For well over 30 years now, I've been muscle testing people for their materials, for any of those things. But I always love it if they're willing to get the blood work drawn too, so that we have something more conclusive.
Absolutely.
Yeah.
I think it's good to have both because obviously the serum test that we're talking about is not a test that tests for the energetics of the material. And so we're testing to see whether the patient develops antibodies to the material, and you're able to see that objectively, and a computer reads it. But I think there's a tremendous value to having someone like you who can muscle test someone, because then we've also tested it energetically. And sometimes those two things, both the energetic testing and the serum testing, give us different results.
Well, I think one thing that we need to look at is that a blood test is always designed to be a quantitative test,
Mm-hmm.
and it has limits as to what it's quantifying.
Mm-hmm.
When we're working with muscle testing, the awareness of the practitioner has a tremendous amount to do with what are we testing, because there's so many levels that some people believe in, others do not, but etheric levels and different levels of frequency that we can test and see if there's doing harm to the person or actually benefit. And some of the new work I've been doing in the field of biogeometry helps us to take harmful substances and transmute them into substances that are not. Are you familiar with the work with the regulation thermometry that came out of Europe, focused on the autonomic nervous system?
Not really. I know just enough about it to be dangerous.
Well, I've also been doing that since it first came to the United States. And the idea is that we can test every one of the teeth, and we can see if something that you might be placing would cause an autoimmune response, or a detrimental degenerative response, or actually even cause the death of a certain tissue. and infection. It's really quite something.
Mm.
And so and they actually have recently added new levels of imbalance to look at with the regulation thermometry that's been very, very effective. And so we can also look from that point of view and see what we can do to assist someone with the issues that they might be having with any type of a material. But I mean, that's not just in the realm of what we're talking about here with our implants. That's also looking at the whole bigger picture. And then we can see what happens a few months after the material's been placed to the autonomic nervous system response, which is,
That's wonderful.
and it's not invasive. It's just, a temperature test with touching different points in a very delicate way on the body. It's really lovely that way. But I wanted to ask you about an area that I've always been a little concerned about with implants, and that is that the material doesn't allow for the natural pressure on the jaw. Could you speak to what that might do to the architecture of the jaw from that lack of movement that a natural tooth has?
Yeah, well, that's a great question because when we started doing and restoring implants many years ago, we would not hesitate to restore an implant, and if there was no tooth next to that, we might go ahead and splint that to a natural tooth. Well, the interesting thing about that is if you lock a natural tooth onto an implant has no movement, whereas a natural tooth has a ligament around it, which acts as a shock absorber to that tooth. And it also pumps nutrients and so forth into and around the tooth. And so when you lock one down with an implant next to it, you can cause problems to the natural tooth because it doesn't have its own movement. That's one issue. Another issue is that, and this is an area of dentistry that you recognize very well, Meridian, is that we know that if we cross the midline, we run the risk of whether it's implants or not, we run the risks of tying up the cranial sutures. Yes. And so you don't have that free flow and mobility that we have in the cranial sutures. So that can be an issue. All of these sorts of things we have to think about when we're trying to restore someone's teeth. What are we going to do to help make this as much like what God made it in the first place, And so I think the other thing that we might talk about in terms of this no ligament around there is implant teeth. So if you try to wiggle any natural tooth in your mouth you can move it a little bit. That's because of that ligament. But if you try to wiggle an implant, unless it's a diseased implant, there's no movement. It's literally fused to the bone. Now, how that plays energetically, how that plays out energetically, I'm not sure. I know that for the most part, titanium implants test very poorly energetically, and usually zirconia test well, but both of them are fused to the bone. So I have a feeling that most people, quite frankly, tolerate the fact that they're fused to the bone and don't have a ligament well, but some people don't. It's either they don't tolerate the material or the body tries to reject the implant, or maybe it is this fact that it's rigid and doesn't have any flexibility. Lane could probably speak to that more because she placed many of them and I have not.
Well, I do think, I echo everything that Dr. Nunley just explained about the ligament and the ability that we have. All of our natural teeth have a little shock absorber in them. If you squeeze your teeth together, that's why you can squeeze your teeth together without breaking them every time, is that they have that little bit of bounce to them, and when the implant doesn't, when you have implants mixed with natural teeth, you have to be very careful with how you bring those teeth together with the occlusion of those teeth, and that can be challenging. And I find that that's what some people have a harder time adjusting to, is they just can't ever quite feel like it feels right to their bite because they're used to something having a little give to it. So that would be not, I would imagine that that would also interrupt the energy there, but from more of the standpoint of that the bite just doesn't feel like it used to because it's not a natural tooth.
I'm wondering also, given what you were just saying about the ligament and the movement, if you think that that's going to affect the circulatory system there, the blood flow into that portion of the jaw, and if that could in the long run have a detrimental effect. And how many years out have you seen, or have we seen altogether, zirconium? Because I seem to recall hearing about them for the first time about 25 years ago. Does that sound right?
In the United States, that would be right. They were finally approved probably about 25 years ago in the United States on a very limited basis. Of course, that market has grown tremendously, and the technology behind it, because there is a push for more biocompatible non-metal material, but they have been developed in Europe probably over the last 40 years or so. So there is data that's longer than just in the United States, as far as what we can look at for their longevity and how patients have reacted to them.
So do we have data on, perhaps different disease processes that might be more prevalent because of a zirconium implant? And then I know we have a lot of problems with titanium. Perhaps you could tell us what those are.
Well, I think that's a very tricky question, in that, as Dr. Nunley mentioned early on, sometimes patients will have a health crisis sometime after having an implant placed. And I would imagine that the majority of the time, the dentist isn't normally thinking that the implant could be a problem if it's not hurting. And so I think that probably gets overlooked. It may have an effect more often than we think. But I also have seen some implants that the patient had no other health issues, and the body rejects the implant fails for no reason that we can find. So I do think it can go back and forth. I haven't seen any good data that would link specifically zirconia implants with autoimmune illnesses. And part of that may be because patients that already suffer from autoimmune issues are more hesitant to have something foreign implanted in their body, which is a conversation we probably have many times a week on if it's the right choice for someone to do that or not. So in answer to your question, I don't think that we have a good study on that, but I think that's more so because I don't think many dentists are even looking for that connection.
And it's not often that we remove zirconia implants. I've only removed a handful, whereas I removed hundreds of titanium implants. Titanium has several characteristics that I think make it a material that we should really not use for dental implants. And one is the fact that the titanium is almost always mixed with other metals. It's really an alloy. The other metals almost always contain trace elements of metals that we wouldn't want, like aluminum for one, and nickel. And those metals don't all stay combined in the implant. They leach out over time. And not only that, but when you biopsy an implant site and remove that, you'll find that the bone around the implant, it's always gray because the bone has become diffused, or the metals have diffused into the bone. And so you now have a very elevated level of the other metals and titanium in the surrounding bone. And much has been written over the years about titanium toxicity, but we rarely ever hear about it. But still, there is quite a bit in the literature about titanium toxicity. And we know that the levels of the titanium in the surrounding bone around implants that have received titanium always exceeds what the EPA would say would be a safe level of titanium exposure. So we tend to try to steer clear of them. I think not only because of that, but because most of the times when we see a patient who said they had a downturn in their health, it was after implant placement, it was a titanium implant, not zirconia. We feel much better about zirconia, but we still, like Lane said, doesn't have your own DNA on it. And we still have to be careful, I think, about who gets an implant.
Yes. Well, I know you have some of the top technology for taking pictures of what's going on inside the mouth, for the jaw, for the teeth, and all of that. Have you done pictures before and after the removal of titanium? And have you done pictures also before and after people have zirconium implants in the mouth? And seen anything you can report about?
As far as, are you referring to like more of a radiograph, like an x-ray picture, or like an actual physical picture of the tissue and the bone surrounding that?
I believe it's one of your latest radiograph types of.
Okay, yes. So the cone beam x-rays, yes, that's been one of the biggest advances in dentistry, is being able to see everything in 3 dimensions. And so to even have be evaluated to see if you are a good candidate for an implant, we always like to see a cone beam, or our specialist that's going to place the implant would see a cone beam x-ray first, so that they can see the bone in the area that we're looking at in 3 dimensions. So that is easy for us to look at with that type of technology. It shows us exactly the width and the quality of the bone that is in that area where we're considering an implant. So yes, you can see that before and see how the bone looks. And then you can also then see that after the implant has been placed, and see how the bone looks around the implant. So that is an easy way to see that. You can also physically, one of the things you asked about with zirconia implants, and I know you were referring to the radiographs, but one of the benefits with zirconia being a non-metal is that the gum tissue, your periodontal gum tissue, really zirconia is much more friendly. The tissue, there's many, many studies on that showing how much healthier the gum tissue is surrounding a zirconia implant versus surrounding a titanium implant. So we do have lots of pictures of that, because sometimes patients' tissues, just on a level that they can see and that we can see, is very irritated around a titanium implant, whereas sometimes when those are removed and replaced with a zirconia implant, the tissue looks completely different. I know that's not what you were asking, but it did make me think of that.
But also, Meridian, we certainly do take post-op cone beams of these patients months down the road if they live in our neck of the woods. Sometimes we just get to see our patients once and then they're off to wherever they live. But if we're fortunate enough to have them come back in a year, we'll take another cone beam to see how that's healed. I would say that we don't see much difference in the way the zirconia or the titanium areas heal, because when we remove the implants, we clean those areas out vigorously. We then put the patients on platelets and stem cells back into that site and close that up in a way that, gosh, they just heal. So it doesn't seem to make much difference.
When I'm talking to my patients about you, and I've sent you people here in Austin, but definitely from all over the country that I work with. And I always tell them about the unique technological support that you can provide to them, as well as everything else. And since I have you here, if you feel like you have the time, I would love it if you would speak a little bit to some of these special types of methods that you use, like the cone beam and the measurements of, the gum issues and all of that. That's part of your regular care for your patients.
Why don't you lead off?
Okay, so we talked a little bit about the cone beam if we were evaluating the bone for the implant, but we also use the cone beam probably even more often to look at all of the teeth and also specifically root canal treated teeth to evaluate what the roots and the bone around those teeth look like. We're able to go all the way around every single root in every single tooth in the head and make sure that everything looks healthy with that bone. And many times we find infections that weren't necessarily painful and that might have been hidden on a two-dimensional, just a standard x-ray. Then we're able to see those very, very clearly. And we're also able to show the patient, this is where an issue is. We can also identify cavitations or areas in the bone that haven't healed properly from old extraction sites. And you couldn't do that before very accurately. And now that tool just allows us to gather a lot more information and diagnose our patients more properly. And so that we've touched on that, and that would be one of the big things that we're able to do. Now, as far as Dr. Nunley mentioned, that anytime we take out an implant or a tooth, we're also able to use ozone and platelets to help stimulate healing and further that along more quickly than just we had when we were only just depending on the blood clot on its own. We now can use platelets themselves to pack into those sites.
Mm-hmm. You know, some of the things that we use are just good old school things that that have been abandoned in modern dentistry and medicine, and that is like just sitting there and loving on the patients and trying to give them and keep them calm. You mentioned the autonomic nervous system a while ago. People always come into the dentist with an amped up autonomic nervous system, and so we want to get them out of a sympathetic state and to a nice, relaxed parasympathetic state. We like to use things like acupressure. We love acupuncture and acupressure just to calm a patient's autonomics. We like to do that before and after, of course, surgical procedures. We personally feel, and there's a lot of good data in the literature about sedating a patient to get them in a nice, comfortable state. We typically use an IV conscious sedation type technique, similar to what someone would have if they had gone in for a colonoscopy, but where they're able to control their own, they have their own ability to protect their airway and so forth, but they're very, very relaxed. And it helps take their memory of the procedure away. We know that absolutely helps with healing. And of course, we love to pray over our patients before we do their treatment and during their treatment, because we're looking for discernment and to make the right decisions during their treatment, and we want the very, very best for the patient. So there are a lot of little things, subtle things that we do to surround the patient in a way that also optimizes their healing.
Well, I know when I had my surgery with you and we cleaned out my cavitations and all of that good stuff, when I woke up, maybe I wasn't really asleep, but when I came back into conscious awareness, there were the hands of a beautiful healer on my face. And it was truly awesome. I just felt like I was floating, in love. And one of the unique things about being in your office, and as a homeopath, I do a lot with homeopathic remedies, even some unusual things with homeopathic remedies to make that process a little bit easier. But one of them I wanted to mention to you is if somebody does have some really nasty types of chemicals or metals in their body, we can make homeopathics of those metals and assist in the process of clearing them out, particularly at the time that you're doing your surgery or just beforehand, so that their body kind of helps with that process of all the side effects that it tends to want to release, in some forms that can be very uncomfortable.
Sure. And we can always provide those for you. We can provide a nosode for you so that you can make your own homeopathics also, even from whatever we find that might be a toxic or infectious nature, so that they can have their own antidote when they return for therapy from you.
it's really wonderful. I typically ask my patients, well, will you please try and just get a drop of
Yes.
that, whatever anesthesia was used, and then
Yes.
we'll make you a specific remedy of what it is that you took. And I teach them how to make them for themselves as well. So, if they can't get to me soon or get them to me soon, they can do it for themselves, or their partner can do it for them, or whatever.
Great.
So I would love to ask you also about the people that you feel would be possibly needing to explore the possibility of some other type of well, actually a zirconium implant. The few people besides being really healthy um, that might want to consider that possibility.
Consider the possibility of doing an implant or not doing an implant and looking at something else. Of doing one. Yeah. So that conversation always starts with, first of all, because a lot of patients that we might see initially to remove teeth, their immune system is just shot. So I always encourage them, we want to talk about the options of implants, but I always encourage them to let their body heal from that initial, not just healing of the extraction site, but letting their immune system recover before we see if their immune system can handle something else. So implants are a great idea in theory, and that you can replace a tooth, it becomes a new standalone tooth, but there's more that goes into it than just the idea of it. So that's the beginning conversation, is where is your immune system 4 months out after we've taken care of clearing out infection? Now we're ready to look at replacing that tooth. So the big question right at first is, where is your immune system? And so let's assume a patient comes back and they've been working with someone like you and they've got their immune system back and functioning strong. So we would need to discuss then that how much bone do they have in those areas, as far as, is it going to be an appropriate area to place an implant? Is it going to require some bone grafting? Or is it close to the sinus and it might require a sinus lift and things like that? So those are all questions to ask, because anytime we're dealing with, we don't have what God gave us anymore, there's going to be some pros and cons on each one of those. So it's a very individual conversation. Each patient has a different set of factors that are going to help us decide what's the very best for them. And so sometimes an implant is a great option to look at for replacing a tooth. Health is probably the biggest thing that we first consider, and then look, because someone could have a tremendous amount of bone in a site, but we might be concerned that their immune system couldn't handle being challenged in that way, versus someone else may need some help with getting enough bone in an area, but their immune system can handle that. So
sometimes too, Meridian, a patient may have had for example, a removable partial.
Mhm.
And they've just finally decided they've had enough of it. Or I just had a patient in this week who has had a removable partial. She has a beautiful voice. And now she's in a band, and she doesn't want to have to deal with that partial anymore. So she's a candidate. She used to have an autoimmune issue, which appears to be completely resolved now. So she's a candidate, in our opinion, for a zirconia implant. That's one possibility. Another is we try to be ultra conservative and non-invasive when we restore teeth here. And sometimes we just do, for example, a little bonded bridge. But sometimes the bonded bridges don't hold up. And in that case, a zirconia implant might be something that we would consider.
Gotcha. Yeah. Well, the big concern, of course, is that midline piece.
Yes.
The midline.
Yes. And if you put, for example, one zirconia implant in, and you're not tying it together with anything else, you've still preserved the ability for the cranial sutures to flex.
Yes.
Yeah.
Years ago, I did a lot of cranial sacral work, and I know how very important that piece is, to allow that full opening and closing and flow of the cranial sacral rhythm.
Yes.
Yeah. Well, is there anything that you can think of that's important to share with our listeners that I've forgotten to ask you?
I think you've covered the implant issue very well. This is a conversation that most times they'll never hear. Usually they will be referred to the implant dentist, and the implant dentist will set them up for an appointment as quickly as possible and put in the implant, usually titanium. But now your audience will be educated on the subject, and they can make an informed decision.
You know, I just flashed on one more question, as long as we're talking about that lack of being informed. Can you talk about the length of time and the whole process that's involved with an implant?
Mm.
And yeah, because it's not just an immediate process.
That is very true. That's probably one of the biggest downsides that I have patients tell me when we finally get to the point, if we've done an implant, that we're getting the tooth finally in there, is they feel like it takes forever. And it does, it is a long process. Normally, after a tooth is removed, we need to allow the body to fully heal that bone for about 3 to 4 months. So we usually tell patients they're gonna need to wait about 4 months before they're evaluated for an implant. And then once the implant is placed, there's a few different factors that go into how long it takes for the implant itself to heal. So just in case someone isn't familiar with what an implant looks like, a zirconia implant would basically look like a white ceramic, almost like a screw. And so that gets placed into the bone. So even though when you put it in the bone during that initial surgical procedure, it's in contact with the bone all the way around the implant. But what happens is then the bone starts to grow and integrate within those little tines on the implant. That's why it becomes fused instead of having that ligament. And that's to make it solid so that it can function. So when the implant is placed, that's why you have to wait a whole nother, usually for sometimes 6 months before the dentist, usually a specialist, like a periodontist or an oral surgeon that places the implant, will have us wait 4 to 6 months before we then can place a tooth on there. So at this point, you're sometimes at 8 to 10 to 12 months from the day the tooth comes out to the day you might have another tooth in. And a lot of it just goes, part of the factors with the healing of the implant are, does the patient require some bone grafting or a sinus lift, as I mentioned earlier, which does sometimes happen. And so when we always tell patients we don't have as much control over exactly where the bone ends up. So sometimes they have to add a little bone with some grafting to allow there to be enough space for an implant. That's a pretty common procedure now, as is a sinus lift when it's needed. And so those things cause the healing to go a little bit longer. That's why we always give a range instead of being able to give an exact amount of time that takes.
And during that time, after the removal and until all of this takes place, I'm assuming that there's going to be some type of tooth placement there so the person isn't walking around without a tooth in that location.
Correct. So if it's a back tooth, like a molar, we generally don't have to do anything to replace that space. But yes, of course, anywhere where a patient might be self-conscious of that space where a tooth is out while that healing period is taking place, we usually have them wear some type of a retainer or removable type of appliance that to everyone else just looks like they have a tooth there, but for them is something that's removable. So yes, that's always an option.
I understand. That's great. All right. So is there anything else now that we've covered that little piece that you might want to share with us? Either one.
I think we're good. It's been a joy, though, to be with you, Meridian.
Oh, thank you so much. I can't tell you how much I appreciate you both, and that your office is there serving people on a level that's so hard to find. So thank you and bless you.
Thank you so much.
Thank you.
You're so welcome.